സെൽഫിയാണോ? ഇല്ല, സെൽഫിയാണോ?
So, good evening, one and all. So, this is our first class in the series of lectures I will be taking. Am I audible? Can you hear me? Is the voice clear?
Yes, sir.
Okay, good. So, let people join in. So, just wanted to start with this topic because a lot of gynecologists have seen that they suffer or they have a lot of issues with the equipment side of it because they go to a lot of fellowships and trainings and they get trained in laparoscopy per se. But when they come back and start operating, they have a lot of challenges with the equipment. They either rely on the technician or the assistant or the biomedical engineer, or they lose track of things when things go haywire during the case. So it's very necessary that wherever you go for a fellowship or a training or any hospital, if you're observing, it's important not only to see the surgery per se, but also regarding the things which are happening in and around the surgery, especially the equipment part. So I'll quickly introduce the equipments. If you can see, this is a medical monitor. To say that medical monitor, because see, a lot of distributors or surgical people fool doctors by cutting down the cost. Like when you try negotiating with them, they'll say they'll give a step down monitor. So this is a medical monitor, and in order to confirm that, you have to see that it's got a DVI cable attachment. So only if there is a DVI cable attachment does it mean that it's a high resolution monitor. Otherwise, what will people do is either they'll give you a USB attachment or an HDMI attachment or a pinpoint attachment and say that this is a good monitor, and they'll cut down the entire cost package for you. But in essence, what is happening is they're not giving you a medical monitor, they're giving you a plain monitor or maybe a TV. So unless and until there's a high resolution DVI cable and a medical monitor, the screen resolution is not going to be good. Secondly, this is the camera unit which comes along with the monitor, and the entire camera unit is this camera unit and the medical monitor. There is a light source. So there are three types of light source. Earlier, when I had started operating back in 2017 or 2015, the light source was halogen light source. Nowadays, halogen light source have been outdated or they've been completely changed. Because halogen light sources were those yellow bulbs which we used to get initially. It had a very short life, so always you had to have a backup during your surgery because these halogen bulbs they break off just like the normal bulbs which we used to have. So halogen light source is out. So if anybody is trying to sell you halogen light source, or if any of your theaters are having a halogen light source, change it, don't use it. It affects your picture quality also because it gives that reddish yellow hue. Then came the xenon light sources. Even xenon light sources are not very commonly used now. Xenon light source is a white light source. Halogen is a yellow light source. So xenon light source also has a limited lifetime. So what happens even during the case of the xenon light source can go and xenon light source becomes very hot. So now commonly what is used and what I personally prefer is an LED light source. So these are LED light sources. We have got two standby because of the number of cases. We have always have two standby for all the equipment. So this is an LED light source. They guarantee a 1 lakh hour capacity for these light source. Even if you don't get that much, it's still worth it. An LED light source is white, bright, and the heat generated from an LED light source is very less. But the main aspect of the talk today, for the most complicated machine, is the insufflator. The carbon dioxide insufflator is something what gynecologists or doctors usually don't understand, and it's the most critical component of your surgery because this is the one which causes the pneumoperitoneum. And my request is that if you've got a high caseload, always keep at least 2 insufflators in your OT, one for a main purpose and one on standby. So if you see, you can see one more insufflator here on standby down here. This is the main insufflator. This is the insufflator on standby. So in the insufflator, what you need to understand is that always any insufflator you take, this is a Wolf insufflator, there's a Karl Stoss insufflator, Olympus insufflator, any insufflator you take, there will always be 3 readings. 3 distinct readings for all insufflators across the globe. So what this means is that if you see under this reading, it says millimeter of mercury. I don't know whether you can appreciate it or not. This is the millimeter of mercury. So this is the intra-abdominal pressure limit you are going to set for your surgery. This reading shows the intra-abdominal pressure for your pneumoperitoneum throughout the surgery. Second one says liter per minute. So that shows the flow rate which the carbon dioxide flows from the cylinder behind through the insufflator, through these tubings into the patient's body. That is a flow rate. I'll come to each one what the significance is. And this one, which is shown later, it shows the total amount of carbon dioxide which is used throughout your case. So once again, pneumoperitoneum, the intra-abdominal pressure limit. This is the flow rate. This is the entire carbon dioxide used during the case. So this is not very significant, but if you want to get an idea regarding how much carbon dioxide each the cylinder is giving or each case is consuming, this will give you the count. And after each case, you can press the 0 button, which will reset the count so that you can assess the amount of carbon dioxide in liters used per case. So when we start the case, our standard is that we set the intra-abdominal pressure to 20 millimeters of mercury. So why I'm stressing on this is that whenever we start a case in a new place, usually the anesthetists they freak out or they get apprehensive because we keep the uh, intra-abdominal pressure at 20 millimeters. So this intra-abdominal pressure of 20 millimeters of mercury is only kept for the initial pneumoperitoneum because we create a pneumoperitoneum using the Varis needle. Once we put the Varis needle in, we insufflate the abdomen till 20 millimeters of mercury so that it nicely balloons out and gives a lot of security and space between the intra-abdominal organs and the skin layer. So that is why we insufflate it to 20 millimeters of mercury. And secondly, when it is so tense and ballooned out, it is easy to insert your trocar without much pressure. Easily the trocar goes in. So initially we set the pressure to 20 millimeters of mercury. And as soon as our first trocar is in, we reduce this to 14 millimeters of mercury. So most of the cases, the safe limit is 12 to 14 millimeters of mercury. We operate most of the cases in this range. So if it's an obese patient, we can even stretch it up to 15. But sometimes what happens is there are some other comorbidities, we can reduce it to 12 also. So 12 to 14 is a safe limit for keeping the intra-abdominal pressure. Now, second thing is flow rate. Flow rate, we always keep it at 10 liters per minute. Now, the catch is that even though you have kept the flow rate here at 10 liters per minute, it depends on what your outlet is. The flow rate depends on your outlet. So I'll practically show you. See, if you're doing your Varis insufflation, whatever be the flow rate there, what will happen is it will usually never exceed 3.5. Are you seeing this count here? This means that, see, I've connected it to the Varis, I've started the machine. Even though my flow rate is 10 liters per minute, this count will never go beyond 3 to 3.5 liters because this is the limiting factor. The Varis needle has a nozzle which will let out the gas only at 3 to 3.5 liters per minute. But as soon as I stop it and I change it to my trocar insufflation, see, I've connected a trocar to it. Now see the reading. Now it will come at entire total 10 liters per minute. So that is the difference. So if your reading, when you connect it to Varis needle, rises anywhere above 3.5 liters, understand that there is some leak either at the machine end or at your Varis needle end. If there is some leak here or there, for example, see, if you're not noticing, I'm just putting it out, the flow rate is going to jump up. Flow rate is automatically jump up because I've put this leak here. So when I connect it back and it comes through the Varis needle, it automatically sets back to 3.5. This applies for Varis and trocar. Even if you connect a trocar and the flow rate goes beyond 10 liters per minute, see, now automatically it has come out and the flow rate has jumped up. I have not done anything. This tube has gone down. It has started leaking and it has jumped up. The second part is if there is any occlusion anywhere, what will happen is that this pressure will instantly shoot up. I'm just occluding this. See the pressure how it has shot up. So when you put a Varis needle or a trocar and you see that the intra-abdominal pressure is shooting up, by any means, it means that there is some pressure or there is some obstruction inside the abdomen which is causing the pressure to shoot up. Can you see the pressure shot automatically shooting up? So the other thing is that this flow rate is used to maintain the abdominal pressure which you have maintained here. For example, you have set it as 14. So as soon as the intra-abdominal pressure or the pneumoperitoneum reaches 14, this automatically gets cut off and this becomes 0. For example, I'll just upload a little. You see that it's gone way beyond. I've set it at 14. It has gone way beyond. The flow rate automatically gets cut off to 0. That is the inbuilt security mechanism for the insufflator so that there is no gas flow when the pressure is low. Now again, I've removed my hand. the pressure is low, so the flow rate will go to the maximum. So these are the nuances you have to understand, because during your case, if you are very thorough with these things, you don't have to depend on any technician or assistant or a biomedical engineer. So these 2-3 things, if you understand, then you'll be very thorough. You don't have to worry about this. So again, repeating, if you connect a insufflator tubing to a various needle, the pressure, the flow rate will be maximum 3 to 3.5 liter. It cannot exceed that. If it exceeds that, there is some leak at the various needle level or the insufflator level. And when you connect it to a trocar, the flow rate is maximum 10 liter per minute. If not, if it is beyond that, there is some sort of leakage. And at any point of time, this pressure of yours, intra-abdominal pressure, shoots up. That means there is some blockage. Could be intra-abdominal, could be in the tube, could be at the machine end, or even in whatever outlet you're using. There could be a blockage. And then if you notice this indicator here, this indicates whether the cylinder is full or cylinder is partially filled or cylinder is empty. When the cylinder is empty, this will go red and this will start giving an alarm here. Usually all insufflators, be it Karl Stoves, Wolf, any insufflator across the board, these are the parameters or these are the settings in exactly the same manner. The left-hand corner will always have the cylinder gas filling, how much it is filled or partially filled or empty. It will always show a red sign here and the alarm will go off. So these are the nuances. Now again, so for example, I finished my case here. I've consumed 16 liters now. Now I want to start a fresh case. So what I can do is I can just press this 0 so that when I start it again, see, I've made it 0. Now next case, I can assess how much of gas I'm going to use for the next case. And with that, you can have an approximation regarding how much one cylinder gives. So this is in short what I wanted to discuss about the insufflator. If you have got any doubts, we can discuss on that. So was it clear what I explained, the parts I've explained? Do you want me to clarify any of these readings or parameters again? Feel free to ask anything. Don't hesitate. We're all just learning. It's not an issue. Okay. Anything you want to ask about the equipment side? This insufflator is one thing usually gynecologists don't understand. Because you go to a training somewhere, some people have some other kind of, what do you say, readings and settings, and they, when you come back and blindly follow it, you don't know the logic behind it, and then you're lost. So everybody does not use this 20 millimeter of mercury. Some people keep it 15, some people keep it 16, as it differs from surgeon to surgeon. But these are the security mechanisms we have developed so that it has worked for us so far. Okay, thank you. It, but still, if you have some doubts related to this topic or anything in laparoscopy, feel free to ask. So if there are no doubts or feedback or comments, shall we close the session?
Dr. Akshay, one doubt.
Yeah.
You said, am I audible?
Yeah, you're audible.
When there's an obstruction, the middle value, the flow rate becomes 0.
When there is an
and
obstruction,
the first value becomes high.
Yeah, see, when the obstruction is there, first automatically what happens is that the intra-abdominal pressure setting shoots up. So when it shoots up, automatically the flow rate gets cut off, because the flow rate is designed in such a way that when the limit which you have set is met, the flow rate will immediately get cut off.
Okay, so when we reach 14, the flow rate should be, if it's very needle, 3.5 and otherwise 10.
No, when you reach 14, whether it is various needle or trocar, the flow rate will become 0.
Okay, yeah, I got that. When the desired pressure
and from
is
there,
reached.
so when the flow rate becomes 0, the pressure will start falling again. And then again, the flow rate will be established.
Okay,
Are you clear on it?
Yeah. Can you repeat that again?
So you have set the limit as 14 millimeters of mercury. So the
Hmm.
aim of the machine is that to pump in gas till the 14 millimeters of mercury pressure is reached.
Yeah.
So when it reaches that 14 millimeters, it stops working. It stops pumping in gas. So there won't be any flow.
Okay. Okay.
So when there won't be any flow, there will be some leakage always through the trocars or absorption in the body or in some other way when you do a suction or
Hmm.
anything. So the flow, the pressure will fall from 14 to 12 again. So the machine is woken up again that it will start pumping
Hmm.
again, flow rate.
Okay, got it. So it's a continuous process.
It's a continuous process. It's a valve mechanism. It's a continuous process. And what I'm saying is that this flow rates will not exceed 3.5 liters for varies, whatever you do, and it won't exceed 10 liters per minute for trocar, whatever you do.
Okay, got
Is
it.
it clear?
Yeah.
It's a continuous seesaw process to maintain the
Yeah,
pressure.
yeah, got it, got it. And so when there is an obstruction, so it's anyway going to go above 14, so the flow rate will go back to 0.
When there is an obstruction, don't consider it as 14. It is anyways going to go about the limit you have set.
Okay.
It,
Yeah,
it
the
is
limit
going
is
to
set.
shoot up infinitely. It's like there is
Okay.
a gas flowing and you're occluding the gas flow. The pressure sensor shoots up infinitely.
Okay.
May go up
Okay,
to
got
40,
it.
50 also.
Okay. Yeah, got it.
This is
Thank you.
across the board. This is across the board. Any insufflator you take, these are the parameters which are going to be there. And this is going to be standard for everything. Maybe the presentation or the display changes, but these are the parameters across the board for all insufflators.
Okay. And is there the amount of carbon dioxide that we use, any significance to that? I mean, in a particular case, it should not go beyond.
No, it's see, there are surgeries varying from 10 minutes to 6 hours also. And carbon dioxide is
Okay.
safe because it is something which is absorbed in the body. So the significance comes for the anesthetist actually. So they monitor the EtCO2 and they will say whether any issues are there or not. But for in a perspective that this much amount of volume is to be used or not to be used, there is no significance. Significance comes when you are doing a long case, you'll have to have an idea regarding the cylinder reserve you have for the case.
Okay.
But it's not very critical because we don't have very long surgeries like neurosurgeries and all. Maximum in oncosurgery may go to 5 to 6 hours. That's the maximum I have done so far. Other cases usually get over in 1 hour. So you don't really have to worry about the volume consumed by the patient.
Okay. Okay. Thank you.
Anyways, good question. Thank you for asking the doubt. Anybody else? Just feel free to ask anything you want. Because anywhere you go,
So,
yeah.
so can you explain from the values how we'll know that we have entered the peritoneum?
Yeah. So, good question. So, my technique of entering the peritoneum is that there are a lot of people who do this negative suction test and taking in with the what you say, put the syringe and try aspirating and seeing. But I don't do all that. Few of you are attending the session have assisted a case with me. So the only thing I do is as soon as I put the varies, usually there is 2 clicks. But with experience, you will understand that what is a giveaway feeling you get after the peritoneum is crossed. Once that giveaway feeling is there, I directly connect the insufflation cable to the varies. The pressure reading in the first, that is the intra-abdominal pressure reading, has to be either negative or 0 or as low as possible. It should never cross 10. The intra-abdominal pressure, as soon as you enter with the varies, usually is always negative. So either negative value or 0 or as less as possible, but will never cross 10. Is that clear to you?
Yes,
Or
sir.
is it confusing?
No.
In short, the pressure initially when the insufflation starts should never cross 10. If it has crossed 10, either there is some occlusion in the varies or either there is some kind of adhesion inside or your varies has not completely penetrated the peritoneum and still is in the pre-peritoneal layer. Some kind of occlusion or obstruction is there if it has crossed 10. Clear intra-abdominal positioning of varies will ideally give you a negative pressure or 0 or maybe somewhere between 5 to 6. It will never cross 10. That is how we
So
realize that it is intraperitoneal.
Any idea from the flow rate also?
Flow rate will never increase beyond 3.5 liters. So if there is obstruction, the flow rate will be 0 or very less.
Okay. Okay, sir. Thank you.
Only look at the intra-abdominal pressure. Intra-abdominal pressure has to be very low. If it is negative, best. Sometimes even with some kind of occlusion or obstruction, the pressure rate may hover around 8 to 10, but that's also fine. That means some momental band is there or some previous additions are there. That is fine, it will clear off. So at that point of time, if somewhere between 7 to 10, what you do is just shake the varies a little bit here and there. So if it is touching some momentum or some kind of obstruction, it will clear out and then the flow rate and then the intra-abdominal pressure will drop and the flow rate will pick up.
Okay, sir.
One last question, if any, if anybody wants to ask anything.
So sometimes there is a fogging of the light. So like some say it is because of the temperature of the carbon dioxide gas. Is there something what we can do about that?
See, it's usually not because of the temperature of the carbon dioxide gas. It's usually because of the temperature of the operation theater. So I think you have joined the group very recently. Some one trick which have experienced through experience we have developed is that if you keep the operation theater temperature as 22 degrees, usually the fogging will be very minimal. What usually happens is people keep the ACs or the temperature at 16 degrees, 18 degrees and sub 20 degrees. Try keeping it somewhere between 20 to 22, ideally 22 degrees, then your fogging is going to be minimal. It is because there is a mismatch of temperature between the external environment and the intra-abdominal environment. That is why this fogging happens. So when you keep the external environment also at a higher temperature, the fogging is going to be minimal. Rest you can always use a hot water flask. But 22 degrees is what I personally experience as a best temperature where you also don't feel warm and the fogging is going to be minimal.
Thank you, sir.
So with that, I think we can wind up the session. If you have any topic suggestions, please do put in the group. I'm planning to do this twice weekly to cover a range of topics, short topics, so that we'll let us meet next time. Thank you. Thank you one and all for attending the session.